there are many strategies into capacity building, but hopefully our strategists today will provide a continuum of case examples of how we can train, provide technology transfer to capable individuals through other modes of long-term training or degrees. So we have 4 speakers today, and our first speaker is Ms. Laurie Krom from the University of Missouri in Kansas City. So I'll leave the floor to Laurie. Yeah?
Thank you, Chaisiri. I have my notes on this computer, so I'm going to attempt to do both. We'll see how that goes. Okay, today I am not talking to you about the ITTC. I'm talking to you about Healthy Knowledge. That is the online learning management system that you may have heard if you went to the first plenary this morning talking about the online UTC and UPC. Joe mentioned multiple times HEK. HEK is Healthy Knowledge. So because I mostly, in this context, am known as the director of the ITTC Network Coordinating Office, I thought I would just kind of reorient you for a second and let you know that I'm actually one of the founders of a group at my university called the Collaborative to Advance Health Services. And we have an 8-person leadership team. Those are our kind of our executive committee and our center at UMKC. And together we have about $45 million in federal grant funding and over 25 grants, 11 national centers of excellence. And so we have quite a large portfolio, and under that big umbrella of the Collaborative to Advance Health Services, one of the hats I wear is the ITTC Network Coordinating Office Director. But another hat that I wear is helping to grow our online presence. We have a huge team not a huge team, a hugely talented team, a very small, hugely talented team that is in charge of our online learning management system, Healthy Knowledge. Erin Hobbs and Hannah Clary are primarily responsible for it. And just excited to kind of share some of the growth we've experienced in this context of thinking about innovative strategies. Our Collaborative to Advance Health Services has expertise in bridging the research to practice gap, and one of the ways that we do that is through online learning. So now I'm going to try and catch up over here. I can go to my notes. Okay. So Healthy Knowledge is a learning management system. So it's not just a website. It's actually a system that allows us to track students to, like many of you probably have at your universities. It's different than Google Classroom. It's a learning management system that can keep grades. It can track student progress. It can make sure that people are advancing through sequences and modules in the way that you want them to. And so we use a variety of funding mechanisms to support Healthy Knowledge. But it was started in 2008 with SAMHSA funding. Some things to note here is that you can take any course on Healthy Knowledge that is self-paced for free for a certificate of completion, which is pretty unique. Now, in the U.S., we have continuing education units, and there's a small fee for if you want to be eligible to get those kinds of continuing education units. But for most people here, that wouldn't apply, and you'd probably be fine with just taking the free version and getting the certificate of completion. The other thing that's unique about Healthy Knowledge is that we have a 24/7 help desk, meaning at any time you can chat or email with someone who can help you if you're having technical difficulties on the site. So if the module isn't loading, or you've forgotten your password, or you can't open a document, there's a help desk there that can help your end users address those technical challenges. And that chat, the help desk is available in both English and in Spanish. So we all know this, probably everyone in this room is an expert in online learning at this point. That was part of the outcome of COVID, is that if you weren't before COVID, you learned very quickly to become either adept at taking online classes or at teaching online classes. And so we know it's experienced exponential growth, and we have also seen that on Healthy Knowledge. Also, because of oh, sorry, my words just flew out of my head. Because of innovations in technology and technological developments, you can access online courses in low bandwidth areas more than you ever could before. Our platform is based on an open source software called Moodle, and that allows the learning management system to be simple and adaptable, so we are able to address challenges, fix bugs. It's open source means that you have a community of developers worldwide who are constantly working on the software behind the scenes, and we regularly upgrade our version of Moodle to address those advancements. We store learning material, conduct tests of student knowledge, and report on student progress all within the system. And Moodle also supports over 150,000 Moodle-based learning management systems in 239 countries. So that is just shows how flexible it is as a platform. So this goes back to some of the growth we have seen since COVID. So in 2020, we had the calendar year 2020, we had 30,436 new user enrollments across the whole platform in the courses that we had. Over 5 million visits to the sites. Over 21,000 users actually completed courses, and over 500,000 completed activities within courses. And you can see how that's grown in 2021 and 2022. So now in 2022, we've had almost 100,000 new user enrollments on the site. Right now there's about, I think last I heard, there was about 300,000 active users on the site, which is very large, much larger than most universities, I think all universities. It's huge. Huge online learning platform, lots of learners. We've had just over 9 million visits to Healthy Knowledge, and we went from 21,000 courses completed to now 83,000 courses completed within that calendar year of 2022. So just huge growth on the site in just the past couple of years. So this is for year 2023. So look, I showed you for calendar years 2020, 21, 2022. This is just as of July 2023. We've had 159,000 new users. So again, increasing by over 60,000. We currently have 253 courses completed and 20,000 activities completed. We did a user satisfaction poll a couple of months ago, and we polled all of the users on the site. We got responses from just about 260, and most rated the site as either good or excellent. So we're feeling good about how user-friendly the site is and how people are able to navigate the courses and the site overall, and then within individual courses. And again, most, in the same poll, most people who responded said that they would recommend Healthy Knowledge to a colleague. Excuse me. So again, most individuals completing this survey said that they would recommend or compare, as compared to other distance learning sites that they have used in the past, most rate Healthy Knowledge as excellent or above average. And most are either very satisfied or satisfied with their experience on Healthy Knowledge. So just wanted to show you these because we feel like we're continually improving the site. We're trying to make adjustments. The more that we can make the site easier to navigate for users, no matter what their context is, the better their learning experience will be, and the more likely it is that they complete activities and then complete courses overall. So you heard a little bit about this morning. Healthy Knowledge has a collaboration with ISEP, and so we host courses for the UTC and UPC. There are 2 ways to enroll. You can either enroll directly on Healthy Knowledge, but the preferred way is if you are already a member of ISEP, and I hope all of you are ISEP members. You can log into your ISEP profile and go to their online learning hub and enroll in a Healthy Knowledge course directly through ISEP. So behind the scenes, we have connected the ISEP website with Healthy Knowledge so that it's a seamless entry point. If you log into ISEP, then you can automatically go there to log into your Healthy Knowledge courses. And then there are 2 kinds of courses, and Joe talked about this a little bit this morning. There are closed, which are moderated courses. So those are instructor-led courses, courses that require you to have a trainer, facilitator, go through the course with the student. Those have to be funded, and they're not advertised on a public site. They're just for you, so you can advertise them to the audience that you want to enroll in the site. And the reason that we charge is not because we're trying to make any money, but literally we have 2 people in my office and a help desk, and we are charged ourselves a per user fee from our hosting platform in order to host the site, and then a per user fee from our help desk company to provide that 24/7 help, which we think is really essential and part of the reasons why we have such high satisfaction numbers on the site. So we do charge a very modest fee for the closed moderated courses. Joe mentioned this morning that Colombo Plan has the ability to provide some sponsorship for those moderated courses. So if you're interested in that, please do reach out to her. And then there's the open self-paced courses, and anyone can register for those at any time. And again, those are free, and you'll get a certificate of completion. I won't go too much into this because I feel like the plenary this morning covered a lot of that. We have universal treatment curriculum courses, and you should be familiar with that. We talked extensively this morning about the UPC courses. Courses are available for the UPC in English and in Spanish. And here are just some courses, some statistics on the UTC self-paced courses. Within those particular set of courses, there are 7 courses available in English and Spanish. We've had just under 7,000 people to date enroll in those courses, and about 2,300 people complete them. And then within the courses, there are activities, so there have been just over 50,000 activities completed within the courses. For the UPC moderated courses, so those are those closed courses that are instructor-led, there are 18 available in English and Spanish, and we've had 69 instances of those courses so far. With that, it might be helpful to show you some Asia-specific statistics about healthy knowledge and the UPC and UTC courses. We've had 18,000 users in Asian countries, and they have conducted about 86,000 use sessions. So that means the user has logged in, they have engaged in the course in some way. So I think that shows that there definitely is a market in Asia for this, that people in Asia are able to access these courses, and that it could be something, if you are in an Asian country, that you want to consider offering to either your students or to professionals in your field. I don't know how big that is. It's very tiny up here. So there are, I think something to note from this slide is that in Southeast Asia, where we are, Thailand accounts for 600 of the use sessions that we have seen of the 44,000 in Southeast Asia. The Philippines, by and large, has had the most. Followed by Indonesia, I see. I think I see some of my Indonesian colleagues in the room. Okay, so what I really wanted to talk to you about, and I know I kind of went through all of that quickly because I really just wanted to set up for you that we have seen success in the Healthy Knowledge platform. We have good satisfaction rates. We have a lot of people using the course, including a lot of people in Asia using the site and going through and completing the courses. So hopefully we'll have time to engage in a bit of a discussion about how you think you might be able to utilize these courses at your own universities. Could you, for example, assign some of the self-paced courses as homework? Could you require upper-level students to be facilitators of the instructor-led courses as part of their own learning and teaching? And how else might you kind of leverage this content in your courses, perhaps without going through and changing your whole curriculum? I know that there are efforts to really adapt academic programming to the UTC and UPC model, but there are other things that we can do even before we go through that whole process to utilize these resources that seem to be effective for a lot of people. So thank you. Here are some of the sources. You'll have the slides, and that's my contact information. Thank you very much. Or ideas you might have on how to use the courses?
Yeah,
Gavin?
I'll make an observation, which I find, at least for me personally and other people who I know, we're tired of having to constantly register for new websites, and an idea for improvement is to just make them openly available without having to first create an account and register and a username and a password and all of that. I think it would improve the accessibility and potentially traffic. Not that you have any trouble with traffic.
Yeah, thanks for that. It's a little bit difficult in an online learning system when we want to track test scores and completion of modules. You kind of need to have a profile in order to do that. But I do agree that We try to streamline that as much as possible, which is why not me, but people who are much more tech savvy than I am figured out how to integrate the ISUP website with Healthy Knowledge so that there was at least one login pathway there. But thank you for that, I agree. Any other questions or comments or ideas?
So I have a question. So how much is your traffic is based on the open like registration compared to the, because your traffic is quite impressive from what you, so my question is, how much of it is closed and how much of it is like?
You mean the closed courses versus the self-paced courses?
The open one where anybody from other places can just register. So.
Yeah, the majority is through the self-paced courses. We have significantly more self-paced courses on the site. I highlighted the UPC and UTC courses, but we have courses, other courses on prevention and treatment. We have courses on alternatives to incarceration. We have courses specifically for mental health, for reproductive and sexual health, and also suicide prevention. So really, there's a lot of on the course more than the UTC and UPC.
So again, if there are more comments,
Yes.
we'll take them at the end, or you can email Laurie if there are any other questions. So I'm going to move on to our next speaker, which Sherry will be moving on to another innovative ways of training and technology transfer. So I'll leave the floor to Sherry.
Great, thank you. Let me get this up here. Perfect. Welcome, everyone. I want to thank ICU-DDR and our hosts for today. My name is Sherry Larkins. I'm from the University of California, Los Angeles, and Dr. Chaisiri was correct. Laurie started huge with a lot of ability to access knowledge and sort of a knowledge dissemination platform with probably some interactive learning opportunities as well, but really sort of high volume. And you'll see through the rest of the presentations, Dr. Bart will come after myself and Dr. Galati after that. And you will see that we're kind of moving on this continuum from really like knowledge dissemination to much more, we'll finish with Dr. Galati with much more like mentorship and hand-holding when it comes to technology transfer and learning and workforce development and training. And so I'm going to talk about what's called the PCSS exchange. And the provider's clinical support system in the United States was developed by, or funded by SAMHSA and developed, I think, by AAAP. And I know Laurie's been very involved in the development of this broader initiative that's really sort of focused on workforce development, particularly with prescribers and people who are using medications for opioid use disorder, essentially to really target a workforce that can treat patients who have opioid use disorders and prevent our extremely high rates of overdose. And so I'm going to talk about one sort of little slice or niche in this continuum of ways to connect and engage learners and develop skills around prescribing. And so I'll talk a little bit about what's behind the PCSS exchange. There is a broad range of PCSS. There's a kind of a compendium or a large catalog of opportunities for training through this provider's clinical support system, ranging from knowledge dissemination to much more intensive technical assistance for prescribers and those who support prescribing. And for the exchange, I'm going to talk about kind of the niche that it fills in this process. And ultimately, we have a little bit of data that were collected for SAMHSA purposes, so you can see people's sort of satisfaction and experience with it. So I think, you know, to restate some obvious things we've been saying throughout these last couple of days is that we've had a lot of aggressive efforts to address overdose in the United States, and yet year after year we've been seeing increases. And so we have a huge need to kind of rapidly expand our workforce and help people get into treatment or engage people in treatment. But that's going to require a workforce that's skilled and knowledgeable about how to treat opioid use disorders. And what we've kind of found historically, and I'm happy that the colleagues that are following me on this panel are both prescribers and have long been involved in prescribing medications for opioid use disorders. And they know that, I'm sure their experience is the same, is that there are many physicians in the United States that get trained on how to treat people with opioid use disorders, and they go through training to learn something, and they never actually treat patients with opioid use disorders. So we have this big gap in the United States between physicians who could do this work but are electing not to do this work for a variety of reasons which kind of range. Some people report, and I think in the previous slide I highlighted that only about 13% of those who are able to treat patients with opioid use disorders using medications, a small percentage of them actually start treating patients and then treat patients at the capacity that they could. So we might find some that treat 1 or 2 patients with opioid use disorders, but they really don't want so many people with opioid use disorders in their practices. So research has been done to kind of look at what are these barriers and what are these practice gaps. And it's things that you might assume. People say, I don't have the training or education, or I don't particularly feel competent to do this. And they'll say, I don't really have the institutional peer support. I feel like I'm a solo operator in this practice. I feel like I'm the only one here that's doing that, and I don't feel well supported. It could be poor care coordination. These might be very complex patients that have a host of other medical conditions, and so the complexities kind of make some physicians a little nervous or worried to take this on. There's always provider stigma. You will find that some physicians, and I hope that this is decreasing, but you will often find physicians that will say, having a few patients with opioid use disorders or addictive disorders is okay, but if I have too many in my practice, and that's their fear, is that they'll have too many of those types of clients. And then we have regulatory issues that make it challenging, whether it's challenging to get the medication or whether it's challenging to get reimbursed for the practice. And so ultimately we have, access and care is an issue, and it's an issue for many people, but it's particularly an issue in communities of color and other sort of minority populations in the United States that really don't get the access they need. So the PCSS exchange, and I'll give Laurie some props here because I think in considering this array of approaches or innovations to target prescribers and maybe systems and organizations and healthcare systems that could be prescribing, I think there was a recognition that there was kind of a population or a slice where we needed more than just knowledge dissemination, but there are people out there that aren't quite ready to totally jump in yet. So I think this fills a little bit of that motivational. If I were using motivational interviewing language, I would say that on a readiness to change scale, our initial target was prescribers that we're trying to engage. They are interested, but not yet willing to necessarily change practice yet and start doing something. So the PCSS exchange is an attempt to sort of engage new prescribers or prospective prescribers as well as their teams in healthcare through kind of ongoing training and technical assistance, essentially. And what was developed was a 6-session bi-monthly. So we meet every other week, and there are 6 sessions, and I'll talk a little bit about what that curriculum looks like. Big objectives are to get people not just feeling that they are interested in doing it, but actually starting to prescribe and starting to help patients with opioid use disorders. And as well as educating those non-prescribers in how they can be champions and support for the practice. And finally, I think one of the best things that this series does essentially is move people on that continuum to more intensive resources that they need. So keeping them engaged, kind of inspiring them, getting them a little motivated, and then hooking them into a lot of resources to keep them maybe engaged in considering beginning to use buprenorphine or other medications for opioid use disorder. And in some ways, how we've done that is our approach has really been kind of an ask the expert. So we have in each session, we have 3 very seasoned prescribers or champions that, while we follow sort of a theme and a topic each session, people have real-time access to experts to ask whatever questions they want, essentially, in this format. And so it is live. We kind of follow a format where we spend a couple sessions exploring, and we're following what's called the EPIS model for implementation and innovation. We spend a couple of sessions preparing folks who are on, then we talk about implementation and sustainability. And we do offer continuing education for a variety, a range. The goal is to be multidisciplinary and bring people from a variety of kind of healthcare backgrounds and get them all to sort of leave this series as champions, essentially. But all of the sessions are designed as a standalone so that there's a theme or a topic each time, and you may not be able to come to all 6 in a row. You may only come to one this session, and then another session you may attend down the line, or you may attend to those that are kind of fill the learning gap that you currently have. So we started, as we were developing the series, with thinking about, do we go for depth or do we go for breadth when it comes to engaging and teaching and training people? Do we talk about sort of the generals or do we talk about the specifics? How case-based should it be? We kind of worked through, we knew that something as case-based as an echo, which Dr. Bart will talk about in a minute, might put a lot of pressure or too much demand on the learner. So we started out with something that's a little less demanding of the learner, that some can sit and listen and start to get engaged, and some can take more active roles. And we wanted to make it as interactive as possible. So there are themes and content each time, but the amount of didactic content is pretty limited, and the amount of case-based learning is proportionally higher. And so the sessions I have listed here about what we cover each week, and we start out, I would say the first few sessions are definitely targeting prescribers and non-prescribers, or medical teams, as well as behavioral and social support teams. And it kind of moves from an organizational preparedness and helping organizations get ready to use a variety of medications for opioid use disorder, to talk about reimbursement and getting top buy-in from your bosses and managers and healthcare systems, as well as understanding the medications better and understanding how you would convey that to patients and how you support patients in this process. And then the last few sessions are definitely are more prescriber focused. They focus on how to induct a patient. We talk about what induction looks like, what challenges there may be, what happens when patients are using other substances, what happens when patients have a co-occurring disorder. And ultimately, the last session is pretty specialized, focusing on how do you treat your pregnant patients who are on medications? What do you do when someone wants to taper their dose or wants to stop using medications? What happens if they're going in for surgery and they're using a medication for an opioid use disorder? Some audience considerations. We talked about how to reach different audiences, how to ensure that people have access to information. We alternated times of day and days of the week to ensure that we could kind of cast a broad net. And we also talked about how to engage kind of organizational and administrative folks, and also some of the key decision makers. Ultimately, it only takes a physician to prescribe or to support, so people could do this solo, but it's really hard to sustain that. So bringing in folks at the organizational level were all things that we considered in terms of being able to scale this and to make this something that's sustainable. Some clinical expert considerations. So each week we have 3 panelists, and those panelists have to be good educators. They have to be not only good clinicians, but they have to know how to teach. They have to know how to connect. They have to know how to engage, and they have to know their research. And so thinking of this faculty mix is important. I actually think the faculty mix is one of it's the most fun for me, and it's a huge strength of this series because every week looks different. We have people coming from a variety of medical backgrounds, so it may be internal medicine and psychiatry as well as a nurse practitioner one week. People are coming from all over the United States, so we have lots of different sort of geographic variation and specialty organization, and people who are working in specialty care and primary care and women's health clinics. It's a broad range. And I mentioned this earlier, but a couple of key things that I think when people end their session, they are emailed a whole host of links, everything from current research to clinical roundtables that follow on the opposite week that are on similar themes and topics, but in a less formal sort of setting, educational videos, and ultimately offers for clinical mentorship and implementation support. So this is kind of like the courting, if you will. It's kind of like, we want to try to get to date 2 with our audience here. And then when we hook them in, we can do more. We can provide you mentorship. We can provide you implementation support for your organization. And so our goal is really to link them to more intensive services and more intensive support. So a couple of the data highlights. We have done this 6-session series 10 times, and I think if it's been funded by SAMHSA, it is up for renewal. I think it'll get funded again, but I don't really know. Do you? Oh, we did. All right. It got funded again. Good to know. But it will be revamped because ultimately this series, I think the genesis of it started pre-pandemic. Through the pandemic, I think a lot of things have changed in the last few years under this funding cycle, at least in the United States. In terms of stigma, I think the continued rates of overdose have created a much more panic mode for a lot of people and a lot of systems of care. And I think that stigma around harm reduction has changed. I actually think professional stigma has been reduced a little bit, where some of the things we used to see among different medical specialties have lessened a bit. And so this series moving forward will look a little bit different, but we did have, we drew over these 10 cycles, we had 5,223 participants. Now, those are not unique. Many of those are repeat. About half of the folks are medical providers, and that includes nurses who can't prescribe, but who play a critical role in really implementing and scaling up medications for opioid use disorder. But that includes nurses, doctors, nurse practitioners, and physician's assistants who were contacted from a variety of ways. I mean, I think I have some data here in a minute about where people came from in the United States, and we really did sort of penetrate all of the states. We had a lot of active participation from all over the United States. A lot of the networks, though, people found out about it through SAMHSA, through a lot of the ATTC and maybe ITTC, mental health technology transfer centers, a lot of variety of SAMHSA partnerships. We were able to disseminate information, and then each session ranged. I mean, we've had as few as 20 people on, and we've had as many as almost 300 people on a particular session. And about half attend one session, and about 10% have attended all 6 sessions, and about 40%, or somewhere in between there, they've attended a few sessions. So again, here from different regions in the United States, we've We've really had people from all over, including some that have come from, that participate from, other countries as well. And I think, ultimately our goal, this piece of data is really about the number of people who come in and say, I am not ready at all to prescribe. Like, I'm not sure I know anything about this or want to do this. It starts out relatively low. So people come to this already with some inkling that they want to consider this as part of their practice. But the number of people who say, I still totally don't feel ready, shrinks a lot after our training series. And most people feel that they have become more ready or more prepared to make changes in practice. People overwhelmingly find that the information and the experience has been a good one. Many of them recommend it. These are all sort of standard evaluation satisfaction indicators that come from our GIP reforms that are required by SAMHSA. Most people feel satisfied or very satisfied with the quality of the session and the professional development. And we have done some focus groups with, I should say, targeted individual interviews, not focus groups, with some attendees to get a sense of what would be more helpful to them or what is missing or what we could include in the future. And we've done this a bit in real time to try to modify the curriculum a bit. People have said that we need to have more on overdose prevention and harm reduction. And so in the last couple of cycles, we have added content that focus more specifically on overdose prevention and harm reduction. We've got more interest in youth. And actually, it's not that easy to find our experts. We have, our panelists are fantastic, but not everybody works with youth and adolescents. So it took a bit of digging, and we have a few people that PCSS has identified. Some people have wanted to know about the effects of opioids and medications on physical or oral health of patients, maybe how to manage referrals of those who have higher level needs and who need more specialty care. And then, of course, there's always, administrative aspects, billing, coding, medical ethics, malpractice. So those are topics that either have been integrated or will continue to be integrated into sort of future discussions. And I think that sort of wraps up our kind of a summary of the PCSS exchange, and I'm happy to take any questions now or when we wrap.
So, so for me, it was a nice transition from an online, interactive lecture to that gap in between people who are practicing. So I think it's really nice. I think something that, at least for us also, it's been missing to encourage people to actually engage in doing substance use and in caring for substance use. I think for me it's really nice. So I don't know if there are any other questions from the audience or not. Okay. So okay. So thank you very much, Sherry. So again, if there are any questions, do let me know or do reach out to Sherry afterwards. So our next speaker is Dr. Gavin Bart from the University of Minnesota. So we'll continue on that spectrum of people who may want to engage, what we can do, and now I think we're moving on to people who do engage and then how we continue to help and train them along the way.
Yeah, thank you, Chaisiri, and I'm so happy to be here. Thank you to ICUDDR for allowing me to present. And this is a great way of building upon what Laurie and Sherry have already presented. And ultimately, I'm going to not so much describe programs, but talk about two different approaches to training, really focusing on ECHO. But at the end of the day, across any training that we do, I mean, this is ICUDDR, we're all about education and training. Ultimately, at the end of the day, do I really care how satisfied people are? Do I really care if I've changed their knowledge, attitudes, and perception? Do I really care what they intend to do with the knowledge that they've gained? At the end of the day, we need to know that the knowledge is put into practice and that people implement what we're training them to do. And so I'll be presenting a little bit about a way we've been able to analyze that for our project ECHO. So when we do education, there are many different ways to doing it. You know, we can do it live in a classroom and have a conversation and teach, but ultimately just plain old lectures, hate to say it, like the one I'm giving, ultimately have very little impact on changing behavior. We can do academic detailing where, you know, we go into someone's clinic and kind of provide them support and hope that that helps improve their knowledge and practice, and it has a little bit of effect. We can come up with brochures and curriculums and guideline books and freely distribute them to people. Not a huge impact. There's really no one magical way of providing education that really results in significant adoption of new practices. Now, ECHO, in case people don't know it, I want to make sure that ECHO is not the same as having a meeting over Zoom. I sometimes think it's just been turned into this generic term, we're having an ECHO. ECHO is not a Zoom webinar, it's not an online training. It's a specific type of learning community that is trying to democratize learning by having collaborative training where people in the field have the opportunity to present cases, discuss them with each other, and have that moderated by facilitators with some expertise in the field and the subject matter being presented. Now, something like ECHO can be effective, but intensive trainings help only so much. So in the United States, for a long time, in order to prescribe buprenorphine for addiction, you were required to do an 8-hour training to get certified to be able to prescribe buprenorphine. Many people didn't do that. And then in New Mexico, the birthplace of ECHO, they started a opioid addiction buprenorphine ECHO to see if that would help people do that. So the gray line here is sort of national trend in how many people were getting waivered with buprenorphine. And then the dark line is what happened in New Mexico once they started their ECHO. Just an incredible uptake of buprenorphine wavering. Very effective. But it was very effective in getting people waivered. Actually, when we look at rates of prescribing of buprenorphine in New Mexico, didn't really change compared to the rest of the country, despite this huge increase in number of people being waived. So, you know, ECHO was really successful at one thing, but it didn't get to the ultimate goal, which is the patients. And Sherry alluded to that many of the barriers that lead to people getting waivered and not prescribed are not feeling supported by the system, not that they don't have colleagues to continue to run things by, stigma, you know, there are all kinds of barriers. So what type of support could help people overcome those barriers? And so I thought an ongoing ECHO in how to provide treatment of opioid use disorder would be valuable. And so the ECHO that we established at my hospital was really geared towards primary care providers and other healthcare professionals with the goal of really targeting multidisciplinary teams. Because if you just train a doctor, but you don't have a nurse involved or an administrator involved, it's really hard to implement practice. Our goal was to help people uptake evidence-based practice using medications for opioid use disorder, specifically buprenorphine, because methadone in the United States can't be provided through primary care at this point in time. And the initial idea was start with a boot camp, which was a live, in-person training, sort of an intensive training that would then have ongoing collaboration through ECHO, although we allowed people to join ECHO without having done the boot camp. And the ECHO is weekly, there are didactics, and people can participate really for as long as they want. Now, my state, Minnesota, from north to south is about 600 kilometers. The widest point, east-west, is about 500 kilometers. It's a population of little bit more than 5.5 million people. Much of the state is quite rural, so we have physicians in rural areas with rural populations with opioid use disorder. They don't have access to specialists or universities. ECHO is very appropriate for them. And we had participants in our ECHOs from all areas of the state. We have 87 counties throughout the state, and I think we had participants in from all but one county. But the map sort of color codes and gives the number of different participants from each area. And what I want to talk about is an analysis. So what was the impact of our ECHO? So we analyzed 306 people who participated in the ECHO at least once, and then using propensity matched controls, we did a 2-to-1 ratio. So we had matched providers, and they were matched on their age, what part of the state they were in, what their specialty was. Were they family medicine? Were they internal medicine? We knew their prior prescribing behaviors, so we did a 2-to-1 matching, so 612 controls, 306 participants in our ECHO, and we looked at, one, did they get waivered to prescribe buprenorphine? Now, some of them were already waivered at baseline, but buprenorphine waiver was an outcome. Did they prescribe buprenorphine? So did the knowledge we helped try to create get put into practice? And if not, buprenorphine, was there at least some medication for opioid use disorder? Their patients end up in a methadone clinic. People attended only one ECHO and then dropped off, but you can see there's a distribution of frequency of attendance at ECHO sessions. Now, what were the results? Again, there are 2 graphs here, and I realize the writing is way too small, so I'll have to describe them a bit more. And this, actually, the updated presentation didn't make it onto this computer. So unfortunately, these 2 panels are the exact same. So I'll only describe one of them. So on the left of both of these charts is really the baseline, the 12 months prior of the number, on top the number of people who are waivered. And you can see during the 12 months there are more people getting waivered through time than the proportion of patients in the middle are who are being prescribed buprenorphine. So again, people, not only are they getting waived, but they're actually prescribing compared to their propensity match controls. And then it's just average number of patients in their practice who are being prescribed to is the bottom. And again, participants in the ECHO were more likely through time to end up prescribing and to a larger proportion of their patients in clinic. Now, unfortunately, what was supposed to be on the left here but didn't show up is showing a dose response. So, you know, there really wasn't a huge impact of change in prescribing patterns if people only attended one session. A little bit of a difference, but not much. Much more of a difference if there were, you know, if you attended between 1 and 5 sessions, and then if you attended at least 6 ECHO sessions, there was a very profound effect. So there's a dose effect of how often or how much you participate in prescribing practices. So I'm going to conclude here with the ECHO and then skip quickly to the next thing. So ECHO participation did increase. So at baseline, people who were participating in the ECHO and the controls were about 16% of them were already waivered at the beginning of their participation. But at the end of their participation, 12 months, we essentially doubled the number of people who were waivered. You know, I'd like to see it go up to 100%, but we doubled it. Whereas there was really no change at all in the 12 months period for the controls. Similarly, we nearly doubled buprenorphine prescribing. So at baseline, the ECHO participants, 14% were prescribing buprenorphine, and at the end of 12 months, 27% were prescribing, so we changed that. And really no change in the control. If anything, a teeny bit of a decrease at 12 months. And as mentioned before, there was a dose effect where you were more likely to be a prescriber the more sessions you attended. Now that short intensive course, remember I talked about a one-day intensive live session, which was the intention to do that and have follow-up with echo. But there were people who attended only the intensive training and didn't do echo. There were people who did echo but didn't do the intensive training. And then there were people who did both. So I'll talk a little bit about this boot camp. And it was a didactic format. Again, we encouraged trios of joining the training. A prescriber, a nurse, and an administrator would be a team attending. And we had common sessions and then separate sessions based on their role to try to provide training specific to their role about, for the administrators, things like how do you bill and code and document for this, and, front desk and workflow, and for the nurses, sort of follow up with patients and managing urine drug testing and side effects, and for the physician, sort of the whole process of prescribing and managing patients. So we did a similar analysis to what I described for echo. We had 125 participants in the boot camp. We did a propensity match control group of 250 people who did not participate in the boot camp. And when I'm talking about the participants here, I'm focusing only on the physician participants, not the administrator or nurses. And similar outcomes. Did they get waived for buprenorphine? Did they prescribe? What about any MOUD? And it's a 12-month before the boot camp and then 12 months following with a difference in difference analyses. Again, low 40s for the average age. Most, more than half, were physicians. About half were from the more urban areas rather than rural. And I think, it was a live training, so it was easier to get to it was done in an urban setting, so it attracted a more urban audience. So I think the part that's interesting and the heart of the matter is looking at buprenorphine prescribing here. On the bottom with the solid colors, we have in blue the propensity match controls, and in red the people who attended the solid blue is no echo and no boot camp. So those are the propensity match controls. The red solid are people who attended the boot camp only, no echo. And we can see that attending the boot camp only did result in increases in prescribing, but we also did the comparison of the dashed lines. Dashed blue are people who attended echo only. And we can see that they had an increase in prescribing. But then we look at what if you did boot camp and echo? And that there's an additive sort of interactive effect that was that led to even greater prescribing. So certainly echo alone is an effective means of increasing. Boot camp alone is an effective means, although echo's more effective, but the two put together produces an even better result in ultimately prescribing. So I think there are many ways we can do education, intensive training. Again, the differences in terms of buprenorphine waiver. Of those who participated in boot camp at baseline, 22% were already waived, but at the end of 12 months, 65%. So we tripled the waiver, whereas in the controls, there really wasn't much of a difference, 19 to 25% at 12 months. Buprenorphine prescribing, again, we doubled it from 23% to 47%, and no change in the controls. And again, there's an interactive effect with echo, so that change from 23 to 47%, there was a greater change if you participated in both. There are barriers to doing boot camps and there are barriers to echo. Echo, by brand name, by use agreement, is a free thing. You cannot charge for it. There is no revenue to be generated from doing an echo, which then means how do you sustain it? How do you pay for your faculty to do this? It's taking their time. So financing the coordination and facilitation is an ongoing problem in the sense you have to do it from grant to grant. It doesn't reach the entire, community. It was really hard for us. The idea of doing case-based learning in ECHO is you have the community come with cases, and there were too many shy providers who didn't want to present their cases, so oftentimes we were coming up with cases for group discussion, but it's best when they can come up with their cases. And as being sort of the moderator in ECHO, it's really easy to revert into teaching mode as opposed to facilitating mode. Those are some barriers with doing ECHO, or challenges. And then again, evaluation. We were lucky we were able to do this propensity match control looking at sort of our state insurance records. But otherwise, most ECHOs are doing the typical knowledge, attitudes, perceptions, or what do you intend to do. And it's really hard to track it in terms of actual patient outcomes. Maybe you can do self-reported patient outcomes, but even those, there's questions of reliability of it. So it is challenging to really document the impact on, say, a cascade of care. So in conclusion, ECHO is a structured approach to learning, and it's powerful, but it might not be right for everyone's needs. You do need to have local contextual knowledge of what the needs are. For us, we needed primary care providers to increase their prescribing of buprenorphine to treat opioid use disorder. And certainly we did find that we were not only able to increase improvements in knowledge, but to access of care by virtue of seeing an increase in prescribing rates in primary care practices throughout the state. So I want to thank the ECHO team in Minnesota, led by my colleague Brian Gran, and then the state of Minnesota, who helped with the state Medicaid analysis for the propensity matched analysis. And then, of course, ICU-DDR for inviting me to this presentation. So thank you, everyone.
So thank you very much, Gavin. So are there any questions from the floor? Again, really nice seeing ECHO data coming out, changing prescribing patterns. Yes, Sherry.
So since there was such a compelling difference once you combined the boot camp and ECHO, or even ECHO alone, but it's for those who have attended more than 2 sessions or above 6 sessions or whatever it was. All of that is self-selected, the folks who decide to stay in, and some people stayed for 40 sessions or something that was a blip at the end. But how do we incentivize people to stay longer? Like, how do we incentivize them to stay engaged in the process?
Yeah, I think that's hard. I mean, timing is hard. Time of day. These are busy practitioners. When are you going to do it? You know, are you doing sort of like what PCSS? Do you try to do it over the noon hour? Do you try to do it at the beginning of work, at the end of the day? We tried playing around with that. That was very hard. I do know Naranjan Karnik out of University of Illinois, Chicago, did a program with actual financial incentives to get a cohort to attend. Now,
right, is it only the self-selection and the self-motivation?
So
right.
Can you incentivize financially for people to do it? At least per self-report, it seemed, for his cohort, seemed to improve it, but it was a pretty heavy incentive. I think people got like $5,000 to participate for a year's worth of ECHOs. Yeah, incentive is challenging.
Yeah. Yeah, I mean, it's pretty remarkable how different, but you have to get people to kind of keep coming back. So what is it that keeps them coming back? Great, thank you.
Okay, so thank you very much. Again, so if there are any other questions, we can always email, or we can compile the questions. So on to our last set of speakers today, so we're right on time. So I'd like to introduce Dr. David Garlotti from the University of California in San Diego, and he'll be talking about an intensive research-focused fellowship I'd also like to introduce Dr. Avirut Onwirum, who is an assistant professor of psychiatry here at Chiang Mai University, but unfortunately he cannot be here today. So I understand you'll be doing, there's going to be a video, and then you'll be presenting. So I'll leave the floor to David.
We actually do have Dr. Unaram with us. So yes, hi, I'm Dave Gurlati. I'm a professor of psychiatry at the University of California, San Diego.
Thank you for the introduction and good afternoon all.
You jumped ahead of me. I'm also a member of the advisory board for the University of California Global Health Institute, which is a University of California system-wide initiative to promote global health. I'm the representative from the San Diego campus. We have many campuses, including Los Angeles, San Francisco, Berkeley, things that other campuses you may have heard of. I'm also on the steering committee for the GloCal Health Fellowship, which is what we're going to describe today. I think it's actually quite fitting. It fits very nicely with our other presentations. I wanted to thank Dr. Chaisiri and the other presenters and ICDDR.
Each region has their own unique specific challenge.
He's so persistent. It's okay, Dr. Everett. You will have your turn. You will have your turn. Anyway, one thing I was struck by. I want to thank everyone here for attending. I know it's the last session of the day, and I'm the last speaker. The Counselor General, the General Counsel for the U.S. Consulate, she actually mentioned how important it is to have research as a part of these initiatives. And so this is going to be an example of research. And we talked about knowledge dissemination, and this is kind of knowledge dissemination and knowledge creation. The research actually, I think, does a great job of providing an opportunity to help people learn about different things and put them in practice. So things like structured assessments for substance use. And I think it can bring attention to areas that may have been neglected and also help empower communities to start doing more to address these maybe previously orphaned issues. So I wanted to introduce Dr. Unaram. As Dr. Chaisiri said, he's assistant professor of psychiatry at Chiang Mai University. He has been a stellar person, a stellar fellow, really an outstanding fellow for our program. A delight to mentor. He actually knows a lot about things that I don't know, not the least of which is how to put your face in a PowerPoint presentation. So I'm glad you'll have a chance to hear from him. He's unfortunately not able to join us in person because he actually has moved on to additional research training at the University of Toronto, and he will be there for a year before coming back and rejoining the faculty here at Chiang Mai University. So without further ado.
Thank you for the introduction and good afternoon all honorable participants in ICU DDR Conference 2023. Welcome to Chiang Mai, the new land, the city where traditional cultures blended with colors of contemporary in Thailand. I would like to say that not only the cultures in Chiang Mai can be blended with the contemporary from all over the world, but also the novel understandings and knowledge from our region that we can learn together. I hopefully aim that this symposium would provide new aspects of mentoring program in substance use in our region, which might be applied in other global mental health settings as well. Since each region has their own unique specific challenging situations, the population of people who use substance in Thailand are found to have higher prevalence in gender and sexual diverse population, and in people who are at risk for HIV infection, such as sex workers or people who engage in transactional sex. That's why the effort to scale up the services in HIV PrEP or pre-exposure prophylaxis is very important in our setting as well. From the aforementioned challenging situations in Thailand, I drafted a research proposal about the substance use in sexual settings and PrEP use, and with the support from the potential mentorship team at that time, from Global Health Fellowship, that tried their hardest to polish the research proposal to be more effective and feasible. Finally, I had a research proposal that adopts mixed methods of qualitative and quantitative study that explores the relationship of sexualized alcohol and drug use, as well as the potential role of mobile health intervention. Mentorship team is the collaboration between regional site mentorship at Chiang Mai University and the University of California Global Health Institute. In Thailand site, Dr. Gingrai, who has been worked closely with the LGBT community for years in the setting of the community clinic and research centers, together with Dr. Chaisiri, who specializes in global health research. With their help, I can approach the specific population in the community easier and collaborate with the M+ clinic in Chiang Mai as well. So for University of California, I have 3 wonderful mentors. First, Dr. David Grelati, who with us today as well, a professor of psychiatry who is experienced in addiction psychiatry, Professor Sangjali, who specializes in epidemiology and career development, and also Dr. Sherry, who is experienced in qualitative study, especially in substance use among LGBTQ population. By integrating the knowledge I learned from all mentors, I would say that I can get beyond the point that I expected to myself to be in terms of research, career development, and global networking. Fellowship is provided by using tailored technical assistance with address stakeholder concern, capacity building, and promote career development at the same time. Professor David would give you the details of each step in the next part. After I received the honorable funded from Global Health Fellowship Program, I started to conduct the study entitled Sexualized Alcohol and Drug Use Among Men Who Have Sex with Men and the HIV PrEP Care Continuum in Thailand, a mixed method study. Our study aimed to explore the relationship between sexualized alcohol and drug use, PrEP, and client needs in qualitative interview. And this prospective study includes the self-reported assessment in the history of substance use, mental health conditions, and other psychosocial factors, and then measure the outcome by using the records of 3-month retention. So we follow the participants in the next 3 months whether they have the PrEP retention or not, and find the links between their behavior of substance use. At the beginning of the Global Health Fellowship, I attended the Forgetty Launching Future Leaders in Global Health or Launch Orientation of Forgetty International Center with the other fellows from 6 consortia all over the United States, and then learning in designing clinical research with structured online coursework from University of California Global Health Institute. Furthermore, the collaboration of UCSD and Cayetano Heredia University in Lima, Peru, provided the diploma in conducting global health research as well. These combinations strengthen my knowledge and skills in conducting global health research in clinical settings. Not just only the research experiences, creating sustainable collaboration with the community agencies and university partners is one of the most important ways. Not just only the UC and the Chiang Mai University, but the network while attending the international conferences to learn the ideas from global health researchers and the substance use education in different areas all over the world will enhance the opportunity to creating research or addiction training program in our region as well. And as a result of the development in research skill and research experience, I would like to share the results, the key findings of my study on sexualized substance use in Thailand. First, around 60% of the participants engaged with sexualized alcohol and drug use, which is higher than previous report. And whereas PrEP retention in people who report sexualized alcohol and drug use were present in the study. Exposure to sexual violence and sexualized alcohol use were associated with worse odds ratio of PrEP retention in our population. The participants still experience stigma of using PrEP, such as during the time they were going to the blood donation, they were rejected to donate their blood. This is one of the stigma that they report. Around 81% of participants reported the use of phone-based sexual hookup applications, and participants found a mobile health intervention would promote PrEP service in Thailand and would be the acceptable way to deal with the PrEP retention problems. So it leads to the next step. First, to deal with the problem on the population who engage with sexualized drug and alcohol use in Thailand. One of the way is the development of mobile health intervention that acceptable in this population from the qualitative study. The second would be the improvement of PrEP services in the community, enhancing PrEP delivery or reducing stigmatization in the people who seeking PrEP. These two ways would be the effective intervention among this population. For the next part, I would like Dr. David Gralotti to introduce the tailored technical assistance in our program that leads us to this point.
So I think that was wonderful, and I think we should give Dr. Unarama a round of applause in absentia. So basically, just wanted to make this point. Here's a definition of tailored technical assistance that I pulled that I thought was equally applicable to mentored research. And so the idea is like if there's a particular problem that you notice, to create an approach that is actually culturally relevant and is able to leverage the process to come up with either important insights regarding and potential solutions to that problem. So in this case, we're doing somewhat of an epidemiological study. If we wanted to try and do introduce an evidence-based intervention into a particular area, we could think about doing an implementation science approach. And the GLOCAL Fellowship is quite flexible. There's opportunity for implementation science, there's opportunity for epidemiological research, there's opportunity even for kind of translational research in the lab. It's a 12-month research project, and there are multiple different countries where we partner, so anyone from these countries could theoretically apply. The idea is that you would get paired with a mentor at the University of California and have local mentorship as well on your project. They accept postdoctoral fellows from these other countries, but the cohort of GLOCAL fellows includes many people who are many of the fellows who are part of the University of California system already. It's funded by NIH. It's actually through the Fogarty International Center, and multiple different institutes contribute to the GLOCAL. I do not believe that the National Institute on Drug Abuse, which is our institute that's actually targeting substance use research, I don't think that they are a participant or contributing institute. However, because of, you think about a syndemic lens, things that are in the field or that are relevant to the GloCal Fellowship, things like HIV, for example, or even hepatitis C. There is a very strong connection between substance use and these other health conditions that you can integrate and build into a proposal so you can address problems related to substance use that way. So this was actually a slide that Dr. Arorut presented. Essentially, there was a lot of preparation that went into his work. Dr. Chaisiri actually approached Dr. Larkins for Dr. Arorut early on in the process. Dr. Lee and I both then got involved and really start to work to develop the research plan and application for Dr. Runaram so that we can kind of have the most competitive application possible. And one of the ideas is it has to be like something that you can, feasible, something that you can do in the time frame, and you only have a year. There's a $15,000 research budget. There's also extra funds for travel to the UC campuses where you're expected to kind of do some local UC work with your mentors for 2 months in California. But the timeline is here, and I think Dr. Runaram actually finished his research doing surveys with and following 100 people in prep care over 3 months within that 1 year time frame, including IRB and all that stuff. There is a core group of principal investigators for this project, including Dr. Lee, who's not here but was on our mentorship team. And there's a GloCal site council, which involves many of the international sites. And I don't know if you can see him here, but Dr. Chaisiri is represented on this little Zoom panel. We are one of several D43 programs that support global health research, and some of these also have opportunities for international applicants. So if anybody's interested, I can point you to the Fogarty website, which has links to all these various programs. They operate at a different university and involve different university consortium for training and providing this type of mentored research. Another thing that is very specific to San Diego UCSD is our Center for AIDS Research. So again, this would be research that's HIV focused, so HIV prevention, HIV treatment, or HIV transmission. And this actually allows for international faculty who are at universities in Mexico, Mozambique, Brazil, India, Kyrgyzstan, South Africa, or Ukraine to apply for a $40,000 one-year research award that where they are partnered again with a with a San Diego mentor to do a research project. Right now, I'm working with Dr. Andrea Gillespie from Brazil on a project looking at substance use and HIV risk in people who are unsheltered in Brasilia. So we just want to thank everybody, the staff at the local community clinic where Dr. Unaram partnered to do this research. It was the M+ clinic in Chiang Mai. Of course, all of the participants. And then he wanted to thank his research team. We want to thank Chiang Mai University, the folks at GloCal, and of course the funders, which included NIH and the University of California Global Health Institute.
Okay, so thank you very much for that last presentation. So more tailored and more intense. Well, not. It only requires 3 months in the U.S., but the rest of the 9 months here, he does receive guidance and training from the local as well. So it's less intensive, but still, I think, very productive and a good way to get research training. So I don't know if there's any questions from the audience. No? Okay, so thank you very much, David. Thank you very much. So again, as the last session of a busy Thursday, so if there are no other questions, I would like to thank everybody very much for attending, and I'll hopefully see most of you tonight, I think. Yes? Okay, thank you.